4, 3, 2, 1. Sir, we are live now.
Okay. Good evening, everybody. Welcome to today's webinar brought to you by the Orthopaedic Research and Education Foundation, India. And I'm Dr. John Mukhopadhaya. Today, we have the pleasure of having Dr. Vikas Agashe from Mumbai, who's going to be taking some interesting cases, which I hope will be interesting for everybody, I'm sure. And whatever questions you want to ask, please free. And we should try and keep this as interactive as possible. So over to you, Vikas.
Thank you, John. Thank you. So first and foremost, will you put on your videos?
Yeah.
All of you, please put on your videos.
You want it on throughout or just when the question?
On throughout. Videos on throughout. They can unmute themselves whenever they are talking.
Okay.
But otherwise, let videos be there. Let me see their facial expressions.
Yeah. Yes, I think
Okay.
from the train or
No issues. No issues. So I can see Avinash. Maharishi is not seen. Ranjan Rai is not seen. Yes. Maharishi, I can see you. Ranjan Rai, will you just put on your video, please?
Ranjan probably is in train, sir.
Okay.
So
Okay.
he may have
No problem.
some problem, yeah.
No issue.
And few of them are still joining, so.
Okay. No problem. So tell me when I will start.
I think just get started, Vikas. We're all ready.
Okay.
Start sharing your screen. And
Yeah, I'll stay. Can you see the screen?
Yes, sir.
yes,
Yeah.
we can. Thanks.
Thanks.
So we have Maharishi, we have Ranjan Pal. Can you put on your videos? Video? Shankar Lal, Ranjan Pal.
I think Rajan is on the train on his way back from Indore.
Okay.
He has a bit of difficulty, but I don't know about the others.
What about others?
Well, you've got 4 people.
So,
he's connected. Okay, so Rajan is also.
So the idea is not to give a talk, but let's stimulate your thinking process. Okay, Maharishi, can you hear me?
Yes, sir.
Okay. Anyone else is live? Anyone else? I don't want to keep on asking the same person.
Yeah, you can see them all. Avinash is there, Narayan is there.
Yeah.
Okay.
Maharishi is there, and one more person, he doesn't have his name. Rajan Rai is there.
Okay. Great. Now I can see all of them. Fine. So let's start with the first case. Now this elderly lady came with discharging sinus, persistent discharging sinus. Doesn't have much pain. You can see the sinus, right? She has a firm to hard swelling in biceps, no tenderness or fracture site, decent range of movements. So to give you a history, she had a fracture neck humerus about a year ago. Year down the line, the surgeon removed the upper humerus plate. After that, she started getting pain in the bicep. She has no pain in the shoulder, can move the shoulder very well. But she has pain and swelling in the biceps and has a discharging sinus. As you can see here, there is a discharging sinus. She doesn't have tenderness over the fracture site. She has a decent range of movement of shoulder. And she has, you can see, displaced fracture with callus formation and collection in left biceps with sinus tract and cutaneous opening. So she had a fracture humerus a year ago. She had a fracture humerus a year ago. She was treated with Philos. The fracture united. Her Philos was taken out. And after that, she developed persistent discharging sinus for 6 weeks and has a swelling in biceps. Now, what
Any
would
reason
your...
for any reason for removing the implant?
No, I mean, I was told that it was just they wanted to remove, that's all.
Oh.
So I don't know why. There was no specific reason. There was no infection, no pain, nothing. So it was just elective removal of Philos. So
And
this is where we are. We have a sinus. So step one, would you like to take culture from here and start appropriate antibiotics? That is number one. And number two, why do you think she may have a sinus here? She has tenderness over biceps, not tenderness, sorry, definite swelling in biceps. She has a discharging sinus. She doesn't have systemic symptoms. She doesn't have much pain, but she has a persistent discharging sinus. 6 months down the line after removal of Philos. And that's the MRI of the hand. And she has a collection here. So would you do a culture? That's the first question. Will you take a swab and start appropriate antibiotics? And number two, what are your, somebody has asked something?
No, sir.
Yes, please.
Sir, I would like to drain the collection and
Okay.
then send the sample of sinus tract and the collection and some tissue around that collection
Okay. So what
for culture.
What would be your incision? Anybody for collecting swab at this stage? Anyone? Vicky, Shankarlal, Pankaj?
So just one question, Vikas.
Yes, yes.
Has the patient been on antibiotics?
She is on antibiotics off and on.
No,
The
but
last taken was about 3 weeks ago. So she
So
fits into that interval.
So 3 weeks she's not on antibiotics.
No.
Okay. She was, I would stop it before doing anything. Or
Right.
at least weeks.
So, Pushpendra, why do you think sir said that he'll stop antibiotics?
Sir, before antibiotic stop is must, sir, because if I am taking swab when antibiotic continue, then no role of sensitivity in this case, sir.
You mean to say that you may get culture, but you will not get appropriate sensitivity?
Yes, sir.
So you'll
Or
get
you may not
culture,
get-
but you will not get appropriate sensitivity. Is that what you are trying to tell me?
Yes, sir.
Okay. Any other opinion?
Or will you not culture it at all? Because
Sir, I think, yes, sir. No organism will appear in culture if
Correct.
we...
Correct. So the bugs are not likely to grow, isn't it?
Yes, sir.
If patient is on antibiotics. Okay, suppose this patient comes in with very severe pain, high fever, she's a diabetic. How long will you wait? Will you wait for 3 weeks, or you will wait longer, or you will wait less time? Very severe pain, lot of swelling, diabetic, high fever, same patient, same clinical, same X-ray, MRI, everything. But our clinical thing is little different. So will you
Sir, I would still like to get the patient fit for surgery and take to the OT and drain the
No.
abscess.
My question is, will you wait for 3 weeks, or will you wait for 4 weeks, or you will wait for about 2 weeks?
Oh.
After stopping the antibiotics, yeah.
No, will you stop antibiotics at that time?
No, sir.
Or you will not
I will.
stop antibiotics?
I will not stop antibiotic, and I will try to get the culture.
नहीं, बराबर है.
you will try to
When?
get the culture. You're going to operate, isn't it?
When?
Yes, sir.
Mane, will you operate immediately or you will do it after 3 weeks?
No, sir, I will operate immediately.
Great. Fantastic. Why?
Sir, because the patient is diabetic and diabetic, that
Perfect.
means low immunity. Patient has low immunity, and
Perfect.
if we wait for more times with the abscess in situ, so the patient may get deteriorated because of the abscess.
Sepsis, sir.
Perfect. Any other opinion?
Yeah, Narayan is not answering anything. So Narayan.
Sir, I would like to go with the Dr. Avinash. He's right, sir.
Okay, great. So you will go ahead. Now, you all know how to annotate. Will you be able to
Yes,
show
yes,
me
sir.
the incision?
Yes, sir. I can. I think.
Yeah, show me the incision. What would be your planned incision?
You know how to do the annotation, no?
Sir, I'm trying.
Just
Yeah,
go to the top. There's a view option.
I think he has done before, sir.
He
Yes,
doesn't.
sir.
He may
I
have
have done
forgotten.
on this iPad
So
only.
there's a view options on the top. Can you see that?
View option.
See, a window will appear only when you take the cursor there. Till then, it will not appear.
Sir, actually, yes, sir. I got it.
Yeah, you
View
got
option. You press that, and below
Yeah.
that you'll have annotate.
third one is annotated. Yeah. He's using window only.
No, he's got Microsoft.
Okay.
Okay. That's Avinash's incision. Any other opinion?
I
Yeah.
include, sir, we include sinus tract in the incision, sir.
Great. That would be your incision. Fantastic. Any other opinion? Any other opinion? Anyone there?
Yeah, Pushpinder. Okay, Pushpinder has answered. Okay, Narayan.
Sinus tract should be
No.
Exercises.
You are going to annotate.
okay, sir.
You agree about this incision or you want something else?
Something else, sir.
Okay.
Bolo
Like
na.
what?
I will take an incision around the sinus tract along with some tissues like this.
So he's already showing that, no? So you'll take a bigger bit in the middle.
Okay. छोटा रखोगे बस साइनस ट्रैक्ट को निकालोगे बाकी
Sinus tract along with the soft tissue, some soft tissue.
You'll just keep that small an incision. Don't extend it proximally or distally. कहाँ से आवाज आ रहा है?
I think
Narayan.
के साइड से.
Sir, the collection is distal, so we can extend the incision distally.
You've just
Can
annotated.
what will you do?
This is
तो
your
तुमने
there ना.
तुमने ही तो बनाया है. Okay.
So I think in these cases you should not be stingy about your incision. Okay,
Yeah.
be prepared to go the full length. If you see the MRI and you know the extent of the infection, you need to extend it all the way. And what do you think is happening actually? Why is it a firm swelling?
Sir, pus collection.
You think it's a frank pus collection or something else?
Sir, I think the bone might show the infection also. The pus is
MRI doesn't show.
You've seen the
any
MRI, does it
infection
show
in the
anything in
bone.
the bone?
Nothing in the bone.
Sir,
It's all along in biceps.
Pockets are
Pushpinder answer.
So what would go in your mind?
It's a
Patient,
firm,
if
hard
patient has
swelling.
and
so,
if
sir.
pus, then don't you think she would be very uncomfortable?
Yes, sir.
So she is not all that uncomfortable. She has that localized swelling. What should you think of?
I think, sir, surgical site infection.
वो तो
Surgical
अभी
site,
ऊपर से
but if
नीचे आएगा क्या इतना? So the reason why I have brought this case is you will see these cases once in a while, but remember, so much pus collection would cause pain, swelling. No, swelling is there, but pain, redness, and so many things. Now that is not there.
so I asked a question earlier was about antibiotics.
Yeah.
Do you think that will make a difference to the?
She is not on antibiotics for 3 weeks. Her pain has not increased.
But she was on earlier.
She was on earlier.
So what are the things you can think of? It's not.
I think Sarkar.
Disappeared.
Yeah, he's coming back probably, sir. वो उनका. Yes, Avinash answer.
Sir, serous collection. There might be some serous collection if the empty space is present there.
Serous collection due to what? It's mentioned that the swelling is hard. Huh? So if it's
Do you
serous,
think
it's-
yeah, there is some foreign body or anything?
Swab. But sir, that
MRI, Vikas. Yes, sir. Hello, sir.
what is going through your mind?
sir, I was thinking of infection and collection of pus.
Okay, but anything that can change the appearance because you're having this.
Sir, other than pus, if it is a sterile collection, then it should be within 10 to 12 days of the surgery. It is appearing late after suture removal. That's why I was thinking of
yes, sir.
infection.
सर वो 2 मिनट सर का कंप्यूटर ऑफ हो गया था.
And sir, no symptoms in spite of collection. There might be due to some low immunity status like diabetes mellitus.
So what are the things you need to think of when something like this happens? One is that maybe you have an antibioma.
Yes.
You know what an antibioma is? What?
Sir, it is a hardened collection of pus due to antibiotic fibroid.
Yeah, so it becomes organized, okay?
Yes, sir.
Because of antibiotics. So you will not have all the classical signs of abscess. You might
Yes,
still have discharging sinuses. Anything else you can think of? Like, I don't know what this case is. I'm just also thinking along the lines.
Yes, sir.
Hello, Janki.
Yes, sir.
Could it be some kind of
Yeah,
other,
well-
not pyogenic? Yeah, Vikas, you're back. He's on the phone.
Yes, sir.
Sir, 1 week ago, I came across a patient, sir. There was a discharging sinus. Actually,
Yeah, 1 minute, sir.
Whenever, yeah.
Sir is here. So, sir told that. ठीक है, sir.
So what is this?
You are able to, yeah. Yes, sir.
So, whenever something like this happens, that there is not, can you see now?
No, we can't see your
Sir?
screen.
Can you see my screen or no?
No,
No, sir.
no.
No, no, sir. Sir,
No?
too much glare is there.
So, whenever there is not much pain, then there is high chance that you are dealing with a foreign body. समझा कि नहीं?
आवाज आ रही है, sir?
Check
Yes,
the
sir.
voice.
I'll just-
So it's a foreign body granulomas kind of thing. Yeah?
Okay, but
So all these things, antibioma, foreign body granuloma, tuberculosis, like
Sir, एक मिनट
Sir,
सर,
but can we keep tuberculosis
मेरे
as
ख्याल
an
से
option
आवाज नहीं
because
जा रही
the
सर,
history is very recent.
6 months.
हाँ, okay sir. Yes sir.
Can you see my screen now?
Yes, sir.
About to. Not
Computer
yet.
somehow is
Yeah.
getting heated. So whenever you have a swelling, discharging sinus like this, not many symptoms, not much pain, think of a foreign body, always. So this is a gauze I looked up. Can you see the gauze?
Yeah.
So
Yes.
that has to be in your mind. Whenever there is not much pain, not many symptoms, at least keep that at the back of your mind, that there could be a foreign body. Huh? And then
Yes,
this
sir.
is 6 months. So important thing is you need to extend incision right up to here. You can't be, as sir said, don't be miser about incision. You need to go to that swelling. You need to expose that swelling. Then only you will be able to address that is the cause of discharging sinus. Barabar ki nahi?
Yeah. So this is something which we've had to deal with a number of times. One good thing about this is that once you take out the gauze, the infection settles very quickly.
Yes.
Unlike if it was an actual infection of the bone or wound, it takes longer. But here, because the foreign body is responsible for the persistence of the infection, once you take out the foreign body, the infection usually settles pretty quickly.
Okay, now let's go to the next case.
So how will we differentiate it with that hematoma if it gets collected? And
So generally,
Explore it, you'll find out, na?
yes
And
sir.
it will show fluid then, na?
so I mean, as I said, the symptoms are not much. She doesn't have much pain, but she has significant swelling. So
Yeah, so
there is
you
a-
get similar things if you have an antibioma.
correct. You
So-
might, the only
Yeah.
thing is generally, you will not have such hard swelling, but not much pain.
Yeah, yeah, but
Generally.
you can do, we've seen a few. You can get it in some of the foreign body granulomas, absolutely.
Correct.
And rarely if it is some other type of infection, not a pyogenic infection.
Yes.
No.
So all I'm trying to say is this has to be kept in mind. That's about all.
Absolutely, yeah.
Any questions about this?
So did the MRI report it as that or it just
No,
reported?
no. Very often it is missed. Most of the foreign
Yeah.
bodies, including wooden piece, is missed on MRI.
But we pick it up on ultrasound quite often.
Yes, yes. But on MRI, generally it is missed. Okay, this was a 60-ish female, minor trauma to her left foot. She just tripped while walking, had a pain in left great toe, and she came in with this X-ray. So can anybody would like to describe this?
I think Narayan, you start. Yeah, you can start. Lytic bone region of the short bones of the foot, and the lesion is.
So both the X-rays of the same side or opposite sides?
Same.
So
AP and oblique.
Narayan, you are not audible here. I think someone else can take over. Yeah. Pushpender?
Narayan, we can't hear you. So
Yeah.
either you.
Yes, Pushpender, you can explain it. Unmute yourself first.
Describe the X-ray first.
Yes,
Yes.
sir. X-ray of left foot, AP and oblique view. That is showing first metatarsal, which is a lytic lesion on first metatarsal, sir.
So where
Anything
to-
else?
And sir, cortex are thin, sir.
Correct.
Is there a pathological fracture?
Yes, sir. Pathological fracture seen in oblique view, sir.
Correct.
The extent of the lytic lesion?
Which part of metatarsal here?
Sir, head, shaft to head, sir.
So distal 2/3, isn't it?
Yes, sir.
Okay. Now, is there the margin is clear or it is breached somewhere? Cortex
Sir,
is breached somewhere.
Medial cortex is breached, sir.
Right.
Yes, sir.
Anything else?
Yeah, I think.
Okay.
You look
So-
for what are the other things you look for? Is there any reactive bone formation? Is there any soft tissue extension? Okay,
Yes, sir.
expansile or not? Of course, that's something you also have to look for.
Correct. So this is a lytic lesion.
Yes, sir.
So what will you do? Will you do biopsy? If you do a biopsy, open or needle, or you will straight away do some surgical procedure? What will be your plan of action?
Sir, firstly, I go for fine needle biopsy, FNAC, and then
Okay.
go for MRI, and then go for
You'll-
biopsy. Then
You'll first do a biopsy and then you'll do MRI.
no, sir, fine needle, sir. Fine needle.
Yeah, fine needle, but would you do that first or you do the MRI first?
No, sir, MRI, then fine needle. And
Okay.
That's not what you said.
Ah, okay. That's your MRI. Some CT cuts.
yes, sir.
Okay, so MRI first because your needle biopsy might change the MRI picture. Okay,
Yes, sir.
you would do the MRI first, then do your biopsy. Okay,
Yes, sir.
if you're planning to do an MRI, if you're not, that's a different issue.
If in your center there is no MRI, then what is your plan?
Sir, X-ray and FNAC, and after FNAC, we plan for if some benign lesion suspected in, then go for excisional biopsy, and then go for procedure for cement or all the fixation or something.
So if it's benign, you want to excise it or you'll do something else?
Sir, benign, then go for excision, sir. Excision and
Anything else? Anybody with any more inputs?
I think Avinash has, yeah.
So are there any other tests you would want to do?
She has a lytic lesion, soap
sir,
bubble
age group-
appearance,
Sir,
something
age
like
group-
soap bubble appearance.
Sir, fluid level is seen.
So what will you do? In addition to all this, will you like to do something?
So,
sir.
is there some other sort of metabolic disease or something which can present like this?
Sir,
Sir,
hyperparathyroidism.
hyperparathyroidism.
Right.
then-
So what will you
what
do?
would you do?
Sir,
Sir,
percentage for PTH and alkaline phosphate and calcium levels or vitamin D level.
Okay, so
Okay.
you calcium, alkaline phosphatase, and vitamin D levels.
So this is where we are.
Okay,
The
so these are
calcium
the
is
first.
10.6, 8.5 to 11. So that is within normal range. Phosphorus is 2.3, alkaline phosphatase is just about raised, and vitamin D is 10.6. These are her levels. Calcium level is normal.
Yes, sir.
So what will you do now?
Next.
So with this low vitamin D, what do you expect? What would be the PTH level?
PTH level would go, sir, higher side.
Higher side.
How
Yes,
high?
sir.
And why?
Sir, it's for bone turnover, sir.
Why is PTH level high with low vitamin D? And what is that condition called?
Anybody wants to help him? Yeah.
Renal osteodystrophy, sir, related with the kidney.
So
You're
I'm
talking about
saying
PTH
that
levels now? Why are you thinking of renal osteodystrophy? Why do the PTH levels rise when you have low vitamin D? That was the question. So don't go off on a tangent because you get yourself into trouble. So what are the forms of hyperparathyroidism?
Primary and secondary, sir.
primary. So what is primary?
It is a main
Parathyroid adenoma or
hyperplasia and adenoma, sir.
Okay, hyperplasia. Okay. And what is secondary?
Secondaries are due to some
We're just discussing it now.
yes, sir.
Low vitamin D.
Yes, sir.
No vitamin
So why
D.
does
And then you also said renal osteodystrophy. This thing level will be high. What is tertiary?
sir,
What is tertiary? So if there is a secondary hyperparathyroidism, there is generally hyperplasia of parathyroids. If that goes on for years together, then one of them starts developing autonomous things. So it develops adenoma or independent secretion of parathyroid hormone. So after years of hyperplasia, they might develop an adenoma. And then it has nothing to do with this. It just continues to secrete parathyroid hormone. So what is the hormone which is antagonistic or agonist of parathyroid?
Calcitonin, sir, is antagonist.
Perfect. So अभी क्या करोगे? Patient has vitamin D of 10, calcium of 10.7. क्या लगता है आपको? So this is one important trick. If vitamin D is that low and calcium is upper border of normal, that means it is very, very likely that you are dealing with both. It is the vitamin D low, in spite of vitamin D being so low, the calcium is at upper range. So you give vitamin D for about 3 weeks or so, and then check calcium again. And in this case, it came to 11.5. So essentially, it was a secondary as well as primary hyperparathyroidism. So PTH was high. Abhi kya karoge? Now we have calcium of 11.5, PTH of 257, patient has lytic lesion. Now what will you do?
Next.
Will you go ahead and fix this, address the bone lesion, or will you ask some endocrinologist to have a look at her? Mane, you will address the hyperparathyroidism first or bone first?
sir, I think sir, we'll fix the bone and then refer it to endocrinologist for
रेफर अगर
hyperparathyroidism.
तुमको ही करना पड़े तो क्या करोगे? कुछ तो कोई इन्वेस्टिगेशन अपने साइड से करवाओगे और
Sir,
you must know at least basics about hyperparathyroidism. So, how many parathyroids are there?
4.
Where are they situated?
Sir, posterior to each upper and lower thyroid lobe
Superior
on both
and
sides.
inferior.
Fantastic. Any other location? So remember, they develop from pharyngeal pouches, 3rd and 4th,
Yes.
and they descend. And since they descend, that descent can be anywhere. So, though in about 80 or 90% of the cases they are where you have said, they are found anywhere in mediastinum or atrium, in the wherever, anywhere from the thyroid to diaphragm. They can be found anywhere. Okay? And then how will you investigate this case?
Sir, first we have to decide it is primary or secondary.
Correct. So I have told you that after vitamin D has come to normal, PTH is 257 and calcium is 11.5. Now where are you? This is primary, secondary, tertiary. (257) PTH, 11.5 calcium. So this is primary, secondary, tertiary.
Sir, primary.
Fantastic. So that means you have to think of an adenoma, correct?
Yes, sir.
So how will you investigate?
Sir, MRI thyroid region, MRI neck for thyroid to rule out parathyroid adenoma and hyperplasia.
So why MRI?
यहाँ पे तुम्हारे टेन्योर में मैनेज भी हुआ है पैराथायराइड का 2 केस.
अच्छा,
आपको याद होना
okay.
चाहिए.
Yes.
सर आप अनम्यूट कर लीजिए सर. जॉन सर.
Sir, MRI parathyroid.
Yes, sir.
Any other investigation? See, we just talked about the fact that the parathyroid may be somewhere else. So what will you MRI? The
What else? Whole body MRI you want? Or
No,
or would
sir.
you do as something else? Is there something, you know, any type of scan that you know that will tell you where the
I think-
parathyroid is?
सर का फिर से चला गया.
Contrast MRI.
Is a scan, huh? What scan we've done?
Which
this?
scan?
Hot and cold.
Hot and cold scan.
Sir.
You think this is like sweet?
So
and
what
spicy?
will you do?
Which scan you know of commonly, which is done in
Sir, bone scan.
उसके अलावा
Is there something else that you do? You do a. Have you heard of a scan?
soft tissue को देखने के लिए
Positron emission.
Scan for.
PET scan. PET CT.
Oh, तुम लोग ना-
Okay. PET CT. Correct?
Yes.
CT would also tell you, but there's another scan which.
thyroid.
There is another
Thyroid
scan.
scan.
There is
Thyroid
another
is-
scan. Special. Correct. It is called system AB scan.
Yeah, it's like a subtraction scan. Okay, so you do like 2 dyes and you get a value from it, huh?
Yeah. So it shows thyroid as well as parathyroid initially, and the dye from thyroid is washed out, and you will see a parathyroid. So system AB scan is commonly used. So in this case, we did this thing, and you can see the adenoma here.
Okay. You see that there?
Yes, sir.
Left.
And more scans are shown here after this.
So USG also picked it up. So now what will you do?
I think sir USG is also known as that thyroid scan, no sir?
No.
Thyroid generally is done for the
You can do an ultrasound scan for the thyroid, but
Yeah.
this parathyroid scan is a specific scan, which is a
scan.
extraction
Okay.
scan. Yeah. Or
So surgery for thyroid was done. Parathyroid was done. Now what will you do?
So we've had 2
How
patients
long?
in
Sorry.
the last few years where we've had to excise the
Yes sir.
parathyroid. one which had to be repeated because the surgeons missed it the first time.
Yes, sir.
Correct.
You guys should remember these things, na?
Yeah, he has seen already, sir. I think why not he's able to answer.
I think it was a bit after the newer guys joined, but Avinash must have been there.
Yeah, yes, sir. Yes.
And there is a very funny thing about thyroid, parathyroid, excision parathyroid. So they repeat the PTH in about half an hour's time.
Yeah,
And if it has not come below 50%, that means they have missed the parathyroid.
absolutely. Yeah.
That is very important. So patient is kept in theater or at least in recovery room for at least half an hour till the report of your PTH level comes.
Is there anything else that you need to monitor once you've removed the parathyroid?
Yes.
What happens?
Sir, PTH
to
level,
these people?
because sir,
Anything
Other
else?
than
I said.
PTH, yeah.
Which can be a major cause of severe complication.
sir, TSH
Next
level,
day,
sorry,
suppose patient,
T3, T4.
patient, sorry,
T3, T4.
suppose patient comes, is seen like this, the resident calls up and says, sir, हाथ ऐसा टेढ़ा हो गया उसका.
Tetany, sir, hypercalcemia, sir.
Hypercalcemia.
Hyper.
Hyper
Hyper
or
में
hypo?
ऐसा होएगा.
Chest excited.
Huh? Is it hyper or hypo?
Hypo or hyper, yeah.
And what is this called?
Tetany.
Tetany, sir.
Tetany.
Tetany.
This is a very important
Not tetany,
complication.
but tetany.
Especially next day, at least 30-40% patients develop this.
Yeah. And you need to watch out because the calcium can drop very rapidly, okay? So you
Huh.
need sometimes even calcium infusions there.
So usually, sir, for
And the other thing you give them is high doses of vitamin D along with it. Okay?
yeah, before that, sir, during that post,
Standard management when you do all these this kind of surgery, and you guys should be aware of it.
And these people have a tendency to say, Ki abhi I have taken out the parathyroid, abhi you take over the case.
Ah,
And invariably this happens.
absolutely.
So they have to be kept in loop.
yes, sir.
Okay, abhi, how long will you wait for your bone surgery?
If you wait
Or you
long,
will do
you may
next
even
day?
have to do it.
No. John, you are answering for them. Anyway, since sir has already answered, you people are knife crazy. This is 8 months, 32 months.
Sir, a
It's
few,
not like the femur where you have to fix it, okay?
Yes.
so few of the answer we got from Ortho TV,
Acha.
like inchondroma, and another one is hyperparathyroidism first.
Huh.
Yeah, this thing. Yes, sir.
There was one more question from there.
No, sir, they have described these things like osteolytic lesion with sclerosed margin over first
Okay.
metatarsal.
Yeah, I wouldn't say it's sclerosed margin, yeah?
Yeah. It's lytic and
Yeah, so this is interesting because we had two patients, one with a
Acha.
pathological fracture of the femur,
Uh-huh.
subtrochanteric. The other was a neck femur,
Uh-huh.
where the patient was being treated for rheumatoid arthritis
Uh-huh.
in the country, including places like CMC Vellore. It'd been to Bangalore, been to Bombay, been to Delhi, been to AIMS, everything.
Uh-huh.
Being treated
Acha.
for rheumatoid arthritis, and she came in with a fractured neck femur and a trochanteric fracture on the opposite side.
Oh.
The person who she was admitted under was going to do a total hip replacement.
Are
But
baap
I
re.
could see her on the ward round, and I said, first check this out, check it out for hyperparathyroidism.
Oh.
Not
So most of these hyperparathyroidisms are missed. Many of them are missed for days together, years together. I've had a patient who was seen by a couple of orthopedic surgeons, and he was referred to a psychiatrist
Yeah, I've seen a lot.
because they
which have been
often
missed.
have mental changes. They have stones, drones,
Bone
and
stones, psychic
bone
stones,
stone
and
growth.
abdominal groans.
Yes.
Stones, bone stones, psychic moans, and abdominal groans.
And abdominal groans. So many of them are referred to psychiatrists, say pagal ho gaya karke. So I had one patient who was bedridden for almost 9 months and was being treated by a psychiatrist. I said, oh, sala pagal ho gaya. Anyway.
So we had one patient who had a proximal tibia, just like a GCT. So he also had a curettage and fibular graft and everything done somewhere before he came to us. He had a recurrence and he turned out to be this thing.
So I will next time, say after about a month or so or two, when we meet again, I will show you another cause of this osteolytic lesions. But that is at a later date. So let's go to this young boy presented with non-healing ulcer. You can see on the medial aspect of the ankle for 6 months duration. 6 months he has this non-healing ulcer, and that's the X-ray. He reported as NAD. 2 previous attempts at no immunocompromised. 2 previous attempts at skin grafting have failed, with mild difficulty in walking, which was worsening over last few days. No fever, no weight loss, no loss of appetite. Now what would you do? That's the ulcer which appears to be reasonably stuck to the to the bone.
Sir, this is a kind of a venous ulcer. This is a venous ulcer.
Very likely, but there was no varicosity. No varicosity. I unfortunately don't have the clinical photograph, but take my word for granted, it is not venous ulcer. So you have a discharging sinus, you have a non-healing ulcer for 6 months and mild difficulty in walking, which is worsening for last few weeks. So if it were only venous ulcer, it is not likely to have pain while walking and pain in the ankle, isn't it? And as I said, there is definitely no venous ulcer. And with venous ulcer, generally you will have swelling, isn't it? Varicosity ulcers will have some swelling there, which is not there. So what will you do?
So what do people think of when something you get a non-healing ulcer? You mentioned varicosities, what else?
Okay, so generally you need to find out whether there is some bony lesion inside, isn't it?
Yeah.
And more important than that, have a good clinical examination. So moment I clean that part, invariably they come with dressing. And you just see the ulcer and say, ki so here now you can see a small discharging sinus. Correct?
So what is that making you think of?
Underlying focus of infection.
Underlying focus of infection. Okay, but what infection?
Sir, bone infection.
What?
No, sir, it is most likely to it's a fungal.
Fungal. Wow. You
What?
guys like to think of complex and unlikely things more than the more likely things.
सर ने पूछ लिया तो टफ हो गया, ऐसा नहीं है, क्या सोच सकते हो?
So describe the ulcer. What are the margins like of that second thing that he's shown you?
Tubercular ulcer is not there, sir.
So what
Undermined.
describe the ulcer now? What is the margin like?
Sorry. Margins are everted and
Sloping
Undermined.
margin is sloping.
Sloping margins are with a slight redness around it.
You think they're undermined or not?
This is not
undermined.
It's not undermined, okay.
Yes, sir.
So we are dealing with some deep-seated infection, correct? Which is very, very likely to be Cox in our country with
Yeah.
discharging sinus with this thing. So
And this is like for me
Sinus.
a physical undermined ulcer, huh? With the kind of discharge you're getting, etc. I mean, you guys don't know what undermined means, obviously.
Yeah.
Sir, edge is hanging and some part of the tissue is eroded below. So that is undermined edge.
So what, this doesn't look undermined to you?
Sir, in my phone, it's. Sir,
Sir, I
Your
think-
phone, it doesn't look undermined, okay.
Okay. So let's go ahead. That's the MRI.
Excellent. Chalo. Now what will you do? Do you have an X-ray?
Yeah, I showed the X-ray. 1 minute. That's the X-ray.
Okay, sir.
Not very.
Not.
थोड़ा सा बड़ा कर सकते हैं
You
sir?
can see it on the X-ray also.
I thought, we can, but that's all.
It's not
I mean,
very clear on this view.
Yes, I mean, it was, I would say, I picked it up only as hindsight. Only after I saw the MRI.
Yeah. So now what?
Now what?
Biopsy.
From where?
Biopsy. Are you thinking of malignancy here?
No, sir.
Then why?
Sir, even for
So you're
tuberculosis.
thinking of you're thinking of non-operative treatment.
Yes, sir.
Why? So in short, what are the indications for surgery in peripheral TB? Let's not talk about spine, but let's talk about any joint, say elbow, ankle, any other joint, peripheral joint. When would you think of surgery? When will you not think of surgery? And here you
Sir,
would say that you would do a biopsy if it turns out to be Cox. You will not treat, rather you will not address it surgically. Am I right?
Yeah.
Am I right? In short, how do you classify the lesion in peripheral joints? TB of classification of TB or grades, you can say. So what are the indications? I mean, this is something which we are going to deal day in and day out, isn't it? I'm not saying this is definitely Cox. I'm saying that in case it turns out to be Cox, then how do you decide when to operate and when not to operate? Some guidelines have to be there, isn't it? Okay. Now I'll ask you, if patient has only synovitis, you do a biopsy, it turns out to be Cox, will you operate or you will not operate?
Not
Sir,
operate.
not
You will
operate.
not operate. Okay. Now suppose somebody has a small lesion well inside the bone. You do a biopsy, it turns out to be Cox, will you operate? You will not operate.
Sir, it is said after starting ATT, after 1 month, if symptom is not improving, then we should operate.
Yeah, but there's some
Okay.
situations where you will not wait, na? If it's already like a lytic lesion with a chronic discharging sinus which hasn't healed over so much time, you want to go in, you want to debride, you want to curate it all out, okay? And if
Yes.
necessary, deal with the problem so that you have a much better chance of it healing. Okay.
Correct.
Yes.
So you have a lesion which is quite big. It has already sort of perforated in one of the joints. So if you wait, the whole thing is going to collapse, isn't it? So you would like to operate, correct? So
And
let's
so
forget
you will
this.
take your biopsy at the time of your surgery, okay?
Yes, sir.
And do take cultures as well. And you want to do what do you call it? Sensitivity tests as well. Okay.
Yes, sir.
Okay. Now, what kind of incision should I take? A, B, C, D, E. This is what would go in through your mind, isn't it? खोलना
Yes,
तो है
sir.
यार, कैसे खोलने का? Surgery तो करना है. What incision
Sir,
should I take?
I think, sir, B.
B,
C, sir. C.
C.
See the whole area where you have the ulcer.
My idea is that if I should drain in the dependent manner. So through the gravity,
So once you do that, you are more or less setting up for a flap cover. Yeah.
Sir, in flap cover in active tuberculosis.
No, but if you're going to take an incision like that, how are you going to close the wound?
Sir, I think that wound is already debrided, and if we take the incision B, we can excise the sinus, and also.
Yeah. So I'm not talking about what you said. I'm talking about someone saying C.
C.
Okay. If you take that incision, then you're going to have a raw area which you're going to have to cover. Okay. So yes, you would take either B or D, but you would want to excise the sinus tract with it. Okay.
Anyone for D? Will you not like to go through a normal skin? Anyone?
B, sir.
Nobody?
No, sir.
Good, great. So
And
obviously you would like, yeah, bolo.
sir, I think for Narayan sir, as he told,
Yeah.
it is from dependent. For tuberculosis, it is written that to drain from non-dependent area, not dependent area. If it is needed, yeah.
Yeah, but I think forget all that in this
Yes, sir.
case.
Yes, sir.
You
It
don't
is
want to
not
go
for this
through an
case.
area where you're going to be sold to a flap. Okay. You want to do it where you can close the wound adequately. You want to excise the sinus, which will take you down to where the problem is. And you want to debride and take proper cultures, etc., from wherever is most appropriate. Okay, so I think that should be very clear in what you're planning. Okay. Yeah.
So that's the sinus. So you can see, as sir said, that's the sinus wall. I've excised the sinus. This ulcer we have not touched. We have kept a small margin there. So and now I can see the granulation tissue here. Can you see that?
Yeah.
Underneath.
Yeah,
Right?
you can see
So
that quite clearly.
we just scraped, opened everything and scraped. Now you can see there's a big void there. And we have I've drained it. That is optional. But with that big cavity, I didn't want hematoma to get collected. So I put in a drain. Now the drain has to be in the line of incision. Why? You can see the drain is in line of incision. Why don't I take it out from here? You see my cursor?
Yes, sir.
Yes, sir.
Yes,
Why
sir.
not from here, or why not from here? Why have I brought it out in the line of my incision?
So that drain, the tract of that drain may form sinus in future.
So you don't want to have another second further wound out there. Okay.
Yes.
Perfect. So same principle is used in any tumor surgery. You take it out in the line of incision. Suppose there is seedling, then you can excise that. Otherwise, if you take it out at right angles, then the tract would get infected. Right?
Yes, sir.
Now, what should I graft the ulcer right away? Since I'm here, should I graft or should I wait?
No, sir. No grafting should be done. Once infection is settled.
You think you'll need to bone graft?
Then I am talking about skin graft.
Skin.
No, I'm asking him. He said no bone grafting should be done.
Acha, I
Once
thought
it is settled, he'll graft it. So I'm asking him whether he thinks it needs to be done.
No, sir. I think after if tuberculosis is settled, there will not be any bone graft will needing.
okay. What about skin graft?
Sir,
So do you think you need to skin graft this area?
2 attempts at skin
Possibly
grafting have
not,
failed.
because once the disease heals, sinus, that area should also heal. Okay, but that's something you have to keep in mind.
Right? So even when he came for suture removal, you can see the ulcer is already healed.
yes, sir.
So it is very often because of a persistent discharge over that area that the ulcer had formed. So moment you stop that discharge, it healed. Right?
Mm,
Now whether you should do a bone grafting now.
No, sir. After when the infection will settle, then it will automatically heal.
Will it?
So here you can see the body is intact. So it is very, very likely what you say is absolutely right. You need not put a graft. So this is culture was positive. All ATT started. This is at 7 weeks. This is at 2 years. No pain. This is at 4 years, and that's the X-ray.
Great.
great, sir.
Excellent.
Yeah, great case.
So remember this saying, it's very important. The persistence of the cause of the sinus is the cause of the persistence of the sinus. Okay?
Yes. Yeah, it is.
Remember
great.
this line, very, very important.
Okay, the persistence of the cause of the sinus is the cause of the persistence of the sinus. And just for non-healing wounds, again, it's the similar thing. Because you haven't tackled the cause, the wound doesn't heal or the sinus doesn't heal. Okay? If you tackle the cause, then it will heal. Okay, great, Vikas. I think.
Okay. Chalo,
time,
bye-bye,
it's,
everybody.
It's
Thank you,
already
sir.
9:30, so I
Bye.
think
Thank
great,
you.
Chalo, bye.
great
Thank you
session,
very much,
and
sir.
it was
Let's-
really good fun. Yeah, great.
Chalo, bye.
Thank you so much.
Chalo.
Thank you, sir.